hear me? And if so, if you could please raise your hand. Very good. That's always a good sign. Okay, well, again, I'd like to welcome you to the webinar. I'm Cherie Wilson, a Faculty Research Associate and a Program Director for the Culture Quality Collaborative, or the CQC, in the Hopkins Center for Health Disparity Solutions in the Johns Hopkins Bloomberg School of Public Health. Welcome to today's webinar, which is entitled Advancing LGBT Patient-Centered Care, Strategies to Create an Inclusive Environment. I will be moderating today's presentation. Of note, an archive of today's webinar will be available on all 3 of our websites. So that would be the Culture Quality Collaborative, or CQC, the Human Rights Campaign, as well as Wilson-Stronks LLC. You will receive a link to these websites after the webinar. A few general housekeeping rules. Hopefully you will not experience any technical difficulties during this webinar, but if you do, please note the number listed below, 1-888-259-8414, and call them, and they can assist you with any issues. Today's webinar is produced by the Culture Quality Collaborative, or CQC, a program of the Hopkins Center for Health Disparity Solutions. The CQC is a network of leading healthcare organizations who have come together to share ideas, experiences, and solutions to problems that arise as a result of cross-cultural interactions within healthcare settings. The Hopkins Center for Health Disparity Solutions is a research unit of the Johns Hopkins Bloomberg School of Public Health. Our center was founded in 2002 by Dr. Thomas Levis and is a National Center of Excellence in Health Disparities Research, designated by the National Institutes of Health, National Institute on Minority Health and Health Disparities. The Cultural Competency Organizational Assessment 360, or what we call the COA 360, is a multi-level evidence-based, web-based cultural competency tool that dynamically evaluates the readiness of a healthcare organization or clinical unit to meet the needs of a rapidly diversifying U.S. population. It assesses the cultural competency of a healthcare organization, not an individual, and it's a multidimensional tool which provides a 360-degree view of the organization unit from the perspective of healthcare administrators, providers, non-provider staff, as well as patients. And in 2008, it received the Innovation Award from the National Institutes of Health, National Center on Minority Health and Health Disparities. And now, I'd like to introduce our presenters. Amy Wilson-Stronks is an independent health equity advocate, consultant, researcher, formerly with the Joint Commission. She currently serves as project advisor to the Joint Commission's ongoing LGBT work, is a member of the National Advisory Council for the Human Rights Campaign, Healthcare Equality Index, and recently was elected to the Board of Directors of the Gay and Lesbian Medical Association. Tom Sullivan is the Deputy Director of the Human Rights Campaign, or HRC, Family Project, and manages the Healthcare Equality Index. And now I'd like to turn our presentation over to Amy and Tom.
Thank you, Cherie.
Sure, thanks, Amy. I'm getting ready to turn the controls over to you.
Oh, okay, great. Thank you. Okay, hi everybody. Bear with me for a second while I get you access to my screen. I hope everybody can hear me fine. I'm sure Cherie will jump in if for any reason the audio is poor. So you should be seeing my screen now. And I just want to thank you all for participating in the webinar. I think all 3 of us were really overwhelmed by the response to this topic, and I think it's really timely, especially today, because today happens to be National Coming Out Day. So it's really great that we're able to offer this webinar on such a timely moment. A couple things about how this webinar came about. I've had the great opportunity to work with Tom for several years on the Healthcare Equality Index, which he'll be sharing in more detail. And through that process, I've really become much more aware of the challenges in healthcare of the LGBT population, and recognizing it as another of our vulnerable populations that require our attention when we think about healthcare equity. So I thought this opportunity, and working with Cherie on some other topics, would be a great one to share reasons for integrating LGBT patient-centered care practices into our overall health equity efforts and quality improvement efforts. So that's really going to be sort of the focus of what I'll be talking about. In terms of our overall session goals, want to share a little bit about what some of the LGBT healthcare disparities are that are existing and some of the experiences of the LGBT population, and also, address and identify some of the legal, regulatory, and of course the quality supports for really promoting LGBT health equity through practices that really support patient-centered care. In addition, I want to share with you some tools that are available to help you as you work with your organizations and as you work individually to really be more culturally competent and culturally sensitive to issues that relate to LGBT health equity. I want to, of course, put one qualifier out there that we have a 1-hour webinar to cover a lot of issues, and I think that I want to make sure folks recognize that LGBT health and healthcare and healthcare disparities is a very, very dense topic. There are lots of resources that are probably too many to even identify in a 1-hour webinar. So we'll really be skimming the surface here. I think what this is going to do, though, given we have such a large audience, is hopefully inspire everybody to go out and learn more, and also to explore some of the resources that we are going to share with you. So the other point I wanted to make is there is a long laundry list of acronyms that can define the lesbian, gay, bisexual, transgender, queer, intersex, etc. population. And for purposes of brevity, even though it is still a mouthful, for this presentation I'll be using LGBT. So we're talking a little bit about identifying healthcare disparities. And this is something that we know is hard for organizations and providers to sometimes swallow. We want to think as organizations that are healthcare providers that we treat everybody well and we treat everybody with dignity and respect, and that everybody receives the same quality of care. And so there tends to be this feeling of, well, it's not happening in my organization, that's sort of not in my backyard philosophy. And this paper, or this article that appeared in the December 10th edition of the USA Today came out right after our last election and basically identified disparities in access to voting rights. And my point for sharing this here is if we cannot get something right one day a year, every 4 years, that has so much national oversight, how can we expect that we don't have similar disparities in our healthcare system that is dealing with so many more complexities? So I think what we want to think about here is recognizing that, disparities can exist. And the only way that we really can work to make sure that they're eliminated or that we're doing all that we can is to really evaluate our practices and understand the needs of our patients who we're serving. So to kind of put this into perspective and to help contextualize some of the experiences of the LGBT population, there was a survey conducted of nearly 5,000 healthcare consumers. And what happened when they looked at the experiences, they found that more than half of these 5,000 consumers experienced one of the following: either being refused needed care, having health professionals who refused to touch them, or health professionals using excessive precautions. They were treated using harsh or abusive language. They had been blamed for their health status, or in some cases they were actually physically rough, physically rough or abusive. The healthcare professionals were physically rough or abusive. And I think that this is, obviously this is a study that was done in 2010, so obviously this is something that we don't want to have happen in our healthcare organizations. And hopefully folks who have not been familiar with this study are shocked at hearing this. But the one commonality that these patients, these healthcare consumers had, is that they all identified as a sexual minority. And interestingly, with looking at just the transgender population and their responses, their likelihood of having one of these experiences rose significantly to about 70%. So we have a way to go in terms of what we can do to make sure that healthcare truly is caring. And I think one thing we might want to do is think, for those of us who work in healthcare organizations, could any of these experiences occur in our organizations? And if so, what can we do to start thinking about mitigating those chances? this actually breaks down the responses from the survey in terms of one of the questions that was asked in terms of being refused needed health care. And you'll see it's broken down by persons who identify as lesbian, gay, bisexual, those who identify as transgender, and then those living with HIV. And there's definitely a significant increase in the transgender population in terms of the disparity of care and the experiences that they have. So we're dealing with a population, we're thinking about population that's really been alienated from healthcare, understandably, because these are experiences that were reported in a 2010 survey, so this is not old data. And in healthcare, we want to help, we want to care for people. But when we think about why we want to even address health disparities and we want to integrate health disparity solutions into quality improvement, we want to think about the links that the role of communication has and the links that it has to patient safety. When I say communication here, because communication is really built on a mutual understanding, that joint establishment of meaning between two parties. And that's going to be really hard to establish if a patient has had the experiences that the Lambda Legal studies demonstrated. So in addition to the communication challenges that exist for any of us, we're also talking about a population of people who many of whom who have had really bad experiences with our healthcare system. So we need to focus on those multiple points for those misunderstandings and look at this as a shared responsibility. So thinking about our own individual behaviors, also thinking about what we need to put in place in our organizations to support care provided with dignity and respect. In terms of health and healthcare disparities, and again, this is general. These are some of the potential causative factors. This is not specific to the LGBT population, but this certainly is relevant. And think about how certain populations may or may not seek healthcare. If you've had a bad experience in the past, you may be less likely to seek out healthcare and seek out preventive care. Also, in terms of the operation of our healthcare systems, there are lots of complexities. As much as the legal and regulatory environment tries to support quality healthcare, it makes it very, very complicated. We know that's why we have a lot of work going on around health reform, because our system isn't easy to navigate, even among the most health literate of us. And benefits are a big issue for the LGBT population in terms of having access to care, because of challenges with insurance status, the challenges of faced with same-sex partners who may not have access and the same availability of insurance as a heterosexual married couple may have, and also challenges in that population because in some states they could actually lose employment for coming out and identifying as LGBT. So those are important things to think about when we think about providing care and supporting this population. Also, the other issues that, of course, affect all of us in terms of our ability to successfully navigate through the healthcare system, which is, time pressure, trying to address issues where sometimes it's easy for any of us who are a provider or even as a patient to prejudge a situation. And there certainly is a lot of work and studies going on around implicit bias and the impact that, our own perhaps unconscious bias impacts how we're actually treating somebody. So we need to start individually keeping that in check. So obviously this is something that is a big issue. Health disparities have been identified in terms of race, ethnicity. They're obviously more now being identified for the LGBT population, although one of the challenges that we have for researchers is lack of access to really good data to do some of the studies that would allow us to better understand how pervasive these disparities are. But happily, there's been a lot of activity at the national level to advance LGBT healthcare. The Institute of Medicine came out with a report recently that actually puts together a research agenda for LGBT health. And this is so significant because a lot of funding for LGBT health was really I guess, minimized, if not nearly non-existent, for many years. So there's actually a larger push and more resources available for this. Also, from the Department of Health and Human Services, the National Prevention Strategy that we should all be thinking about when we think about health and healthcare and the role of prevention is advocating for more culturally competent health workforce. We hear a lot about cultural competence, and cultural competence is really about being able to respond appropriately to the needs of our populations and work in a culturally competent organization. It also addresses standardization and collection of data, and that includes population data on sexual orientation and gender identity, which is a significant improvement and push for better understanding our LGBT population. A couple other areas of activity include Healthy People 2020. This is actually specifically included in their goal to eliminate disparities. The LGBT population is included as that. And they have a specific LGBT focus area, as opposed to in 2010 when there was actually a separate report that addressed LGBT care. This is actually integrated into Healthy People 2020. So we're seeing more integration and inclusion of the LGBT population in broader issues to address diversity and health disparities. Lastly, another significant point that will hopefully provide additional data is that the National Health Interview Survey is now going to include sexual orientation and gender identity as one of the questions. In addition to those national efforts, there are a couple efforts that are going to have probably more significant impact on actual care provision at direct care organizations such as hospitals. Specifically, work that came out of President Obama's directive to HHS to make sure that the conditions of participation were overseeing inclusive visitation rights for same-sex couples. And this came out, and also at the similar time, actually just in advance of this, the Joint Commission proposed and had adopted new standards that specifically require non-discrimination efforts in organizations and hospitals that are inclusive of sexual orientation and gender identity and expression. In addition, the Joint Commission is now working on a field guide that is due, as of today, due for release on November 7th, and I hope my colleague Brett Schertz from the Joint Commission has joined us, but I think it's going to be a very helpful resource that will further integrate knowledge about and resources related to LGBT health into our efforts to eliminate health disparities. So I had the pleasure and pain of participating in the development of the new and revised standards at the Joint Commission while I was there. And I think whenever we think about Joint Commission standards that address health equity and patient-centered care, I think it's important to realize that the Joint Commission has really always had standards that support these issues. And these are some of the standards that really support this, although it's certainly not an exhaustive list. But the Joint Commission has expected and promoted education in terms of cultural diversity and ongoing education related to the population served. Compliance with law and regulation, patient education, a patient's right to have effective communication, so to be treated in a manner that elicits that patient's information and provides information to patients in a manner that they're going to understand so that they can participate in care and so that they have informed consent. What we realized, though, with the standards in several areas is that there were some gaps, and because the Joint Commission had been so forward-thinking many years ago, we needed to kind of look back at these standards in light of what we'd learned about practices that really that promote health equity. So some of the new or revised requirements that are specific to this topic include, first of all, effective communication. And I think I include this here because effective communication is for every patient. It's vital that patients are encouraged to participate in their care process, but that is inhibited if they aren't encouraged to effectively communicate. but also allowing patients access to a support individual is vital. And you know, this is hindered in many cases for LGBT patients and same-sex couples in a way that it's not usually hindered for heterosexual couples. And then also, of course, ensuring care that's free from discrimination. This seems like a no-brainer, like it shouldn't need to be in the standards at this time in our society, but unfortunately, based on what we've learned from the Land Legal Study and others, we know that these issues happen. So it's good to have a placeholder to say, you know, we cannot do this. This is a guidance. This is part of our ethics and part of the way we do business, and it's non-discriminatory. Also, there are some clarifications by the Joint Commission that specifically reflect visitation access as per the CMS conditions of participation. So the Joint Commission, in addition, has come out with a roadmap that includes LGBT resources and the and considerations of the LGBT population in its efforts to advance effective communication, cultural competence, and patient and family-centered care. And this is because it's really important to think about this as thinking about how we're providing care and how we're developing systems that are going to meet each individual patient's needs. And for those of you who haven't had a chance to look at this free resource, I definitely recommend downloading it. It is available on the Joint Commission's website, and it gives a lot of guidance to you about many topics, including this. So we've come a long way, and I think that's great. I think that the fact that even the Institute of Medicine has put out a report on the LGBT population in terms of guiding research. We know that the Institute of Medicine has really been very formative in guiding policy, but I share this slide because these are some of the reports that the Institute of Medicine has released that have really done a lot to raise public as well as professional awareness of some of these issues related to quality. But I have you take a look at the dates of specifically the To Err and Human report identifying medical errors. And 1999, it's been a while, and we know that we still have a long way to go. And so while I think it's wonderful that the IOM is now addressing these issues, I think we have a long road ahead of us, because even if we think about general racial, or if we think about racial and ethnic disparities and disparities related to language access, we're still on the continuum, kind of moving towards the practices that we know can help us better understand and address those issues. So not to be a naysayer, though, I think there are a lot of ways that we can improve our capacity to make sure that all patients make it through the healthcare system successfully. And I think cultural competence is a significant part of that activity. And cultural competence can be defined in many ways. But I just happen to like this quote because I think it really speaks to sort of the heart of what we're talking about when we think about the goal of cultural competence. And it's that only a person or a nation self-confident in the best sense of the word is capable of listening to the voice of others and accepting them as equal to oneself. Let us try to introduce self-confidence into the life of our community and into the conduct of nations. And I think what we're trying to do is really empower our patients and recognize that our patient's voice is as important as our own. And we need to think about the systems that can allow that. As part of a study that I did several years ago that looked at how hospital CEOs understood cultural competence, we realized that they do believe that this is important. And as we know, hospital policies and priorities are often driven by leadership. And this is an example taken from a quote by one hospital CEO that says, "We feel the overall cost benefit is there. We may not show it in direct dollars and cents. A lot of times costs just look like operating expense. But if we can get people established with primary care instead of using the ED, it is more cost effective." And we're always looking at ways to demonstrate that. So this was a study Sunita Mutta at UCSF and I did, and it was focused, though, on data that was collected specifically around racial and ethnic disparities. But I think the message is clear. And one of the challenges with promoting racial and ethnic and linguistic healthcare practices that are inclusive is the cost of things such as language access services. if we think about what we're talking about now, I think we are we have a benefit that there should not be that additional cost for what we want to do, aside from what we might want to do to invest in better understanding the community that we're talking about. So I wanted to share some examples of things that can be done both at an individual level as well as at an organizational level, because I think this is something that is an ongoing process. I've worked in the area of cultural and linguistic competence for many years. I think that one of the things I realize is that I'm never going to be an expert. I am never going to entirely understand anybody else's culture, but I also recognize that it's very important for me not to make any assumptions about someone based on their appearance or based on a certain set of information that I may have obtained. So what I do need to do, though, is try to educate myself. For persons who are clinicians especially, but also anybody in the healthcare environment, prepare to treat patients who may come in, you may not have had the opportunity to treat before, such as the transgender patient population. Become familiar with their needs, with some of the language. And there are resources that can help and that are available to guide individuals through this. I think that this is a topic that can be very uncomfortable for people. And I think we have to give ourselves a bit of credit for being able to ask questions. But asking those questions in a manner that creates an openness and a shared and safe space for us and for our patients or for our colleagues with whom we work, who may know more about some of their experiences than we do. So this also means using respectful language. And some of the simplest things can really help create an environment that's more welcoming for the LGBT population, such as instead of making an assumption about how a patient would like to be called in terms of a pronoun or what name a patient may like to be called because it may differ from their legal name, it's helpful to ask the patient. And these are things that we can do ourselves, and we can also train and share these as examples of really good practices with our colleagues and staff. It's important to also ask these open-ended questions. And I want to emphasize as I'm saying this that these are not unique to working with the LGBT population. I think they're expressly important with the LGBT population. But I think any of us can recognize that we don't want to necessarily have anyone make assumptions about us. So opening up and admitting when we don't understand is also important. This is a continuum, and I think we have to be comfortable with our discomfort or learn to acknowledge that there are going to be times in which we're uncomfortable and feel confident to ask for clarifying statements. And in encounters with patients, perhaps ask the patient to repeat what you think you've heard from that patient and make sure that the patient can tell you, is that truly what that patient was trying to portray or trying to explain. And lastly, although I'm sure this is not a complete list, but it's really important to ensure confidentiality because of the experience that many patients may have had in terms of being treated with less than dignity and less than respect, to really create that safe space and explain how the information that they're going to share with you or that they're shared with you is being kept sacred and kept confidential. And share when there's information that won't be able to be kept confidential. So what can my organization do? There's a lot of things that an organization can do, and I think this is also something that the Joint Commission resource that will be coming out next month will be very useful for, but to share a few things. Simply posting inclusive non-discrimination policies and making them very apparent can be helpful. And this should also include employment practices and employment policies. And Tom will talk a little bit more about that as it relates to the Healthcare Equality Index. Making sure that forms are inclusive in terms of the language that's used, because a patient who may come in and only be able to, check marriage status may find that a little bit off-putting, particularly if they're partnered, for example. So it's better to say relationship status instead of marriage status. including transgender in addition to male-female options. And there are several resources that are useful. I know that the Gay and Lesbian Medical Association has some guidelines for the treatment of LGBT patients, and it has some examples of how you can word these questions in a manner that will be more inclusive so patients have the opportunity to share this information if they're comfortable. Also, hiring an LGBT staff, and also in your organizations creating LGBT employee groups. That is an opportunity for you to allow folks to come together and share their experiences. And I think if we don't ask about how well our organization is treating its employees, we're not going to learn about how we can improve. Something also I think is interesting is having unisex bathrooms. It may not mean that your organization has to have all of its bathrooms unisex, but making that an option that's available, and it's available prominently, is going to be very, very important too. And then lastly, but certainly very, very important, particularly as we think about what we want to do in terms of integrating this into quality improvement efforts, is to assess your policies and your practices as part of your ongoing quality improvement process. And also to include how well staff are interacting and the practices that they're engaged in as part of their performance evaluation, making sure that staff are all committed to treating every patient in a manner that promotes that patient's dignity and respect. So really what we're talking about, again, with all patients and also with all organizations, is one size doesn't fit all, but we are dealing with complex issues, but sometimes all we need to know about are really who are our patients and some of the simple practices that can be put in place that will elicit understanding from our patients, trust in the healthcare system, and eventually, ideally, better health outcomes. And this slide is one that I use in many conversations just to share that we're looking at a diversity of patients. But the shared goal with all of the patients who are identified in this slide is that they want to come out of the healthcare system better than they came in, and they have unique needs. And it could be the patient who has a language need, or the patient who has social challenges because they can't access transportation, to the patient who has had bad experiences in the healthcare system and is unable to, is not treated respectfully because they are coupled with a partner of the same sex, and they're not allowed access. So there are lots of different things that can influence some of these issues. So to wrap up, I want to be able to turn this over to Tom to talk more fully about the Healthcare Quality Index, because I think it's an important tool that can be used as a step towards really assessing an organization's inclusiveness by evaluating its policies. So if we think about how we might want to include or create that inclusive environment, we're talking about considering things that are in some of these areas of, or these domains actually, of cultural competence, which one is leadership, so looking at policies and one's mission, thinking about our workforce in terms of training and performance evaluation, evaluating care practices, including communication and practices that support a communication, and how practitioners across the organization, I shouldn't actually say practitioners because it's also as equally important that our administrative staff and staff who are at registration and in billing are sensitive to these needs, and also sensitivity to clinical needs. Data is an important piece of this. There are efforts at collecting data around sexual orientation and gender identity at the patient level in organizations. I think that that's something that is still being developed in terms of best practices, but it will be something if we can get our systems down for doing that, it would allow us a lot of great information and access to some research studies that we don't currently have. And then lastly, thinking about how we can engage our community. Making a more inclusive environment for the LGBT population can also be a really great marketing tactic for organizations in terms of increasing their market share. So lastly, what an inclusive organization has done, it's assessed its environment, it knows what its resources are and what its deficits and needs, has a plan to monitor this, and it promotes this inclusive environment at the patient level as well as at the system level by educating staff, gathering feedback, and including this as part of the ongoing workforce evaluation. So I'd like to actually turn this over to Tom because I think, again, the Healthcare Equality Index is a tool that can be used not only to help organizations evaluate their policies, but also engage in some discussion and information around other practices that can really help support this idea of an inclusive environment. Tom, can I hand it over to you?
Yes, you may. Thank you very much, Amy, and I really appreciate all the people who have joined the webinar today. I think many of you may be aware or have heard of the Healthcare Equality Index, but I'm going to start with a brief introduction of what the project is and what I do in relation to that and how it relates to the subject matter that Amy covered. The Healthcare Equality Index is a project of the Human Rights Campaign. It's been something that we've done for about 5 years now. At the center of it is an annual survey that we conduct nationwide. Thus far, primarily hospitals and clinics have participated, but we do want to make this an industry-wide type of resource. The survey focuses primarily on 4 areas of policy in healthcare. And those are 1, patient non-discrimination policies, 2, visitation policies, which are most relevant to hospitals, of course. Third would be the cultural competency training on all of these subject matter. And then 4th would be employment non-discrimination policies, which we find are a very good indicator of the openness and inclusiveness of a facility. So the nice thing about the Healthcare Equality Index, and I'm biased because I work with it all the time, and I really appreciate the opportunity to work with hospital and healthcare representatives all the time on this, is that it acts as a self-assessment tool. All of the things that we've been talking about today are these incredible advancements in policy and in healthcare, from things from the HHS on visitation to the Joint Commission's patient-centered care standards, which relate to patient non-discrimination. But there needs to be some understanding of how to make those policies and those regulations have the full effect that we want, which is to create a healthcare experience that's equitable for everyone, including LGBT patients. So the Healthcare Equality Index is an annual survey. Any facility can participate. There's no charge for participation. And at the end of this presentation, I'll make sure everyone has the contact information where I can send you the survey participation invitation. Each year we conduct the survey from October through the end of the year, so I think it'll be early next week that we'll be sending out invitations. So this is a very opportune time to introduce this to everyone. The survey not only has the specific policies that I referenced, patient non-discrimination, visitation, training, and employment, but also has some other background questions that are more just for educational purposes about the ways that data are collected and how training is conducted on things like advanced healthcare directives. So it becomes not only an experience for people to evaluate those specific policies that are reported in the Healthcare Equality Index report, but it also creates a discussion around a broader range of issues, some of which we've been discussing today. And what we find, and this is something we can go into more in depth, and I can certainly send anyone copies of the report who are interested. What we find from the participants is that in the process of evaluating these few policies that we rate, they create a discussion among the staff at a healthcare facility that bring to light a whole range of issues that had not been considered before. One thing you'll find is that many times you hear stories of discrimination, and there's a slide on this presentation about one in particular that many of you may have heard of. Janice Langvin and her partner Lisa Pond were in Florida in 2007, ready to go on a cruise when Lisa suffered an aneurysm. The experience that Janice and her children had at the hospital was an extraordinary experience of discrimination, where her advanced healthcare directives were basically ignored because, as the quote is reported, she is in an anti-gay state and an anti-gay city, so she doesn't have those access rights, hospital visitation. That led to the President's memorandum on hospital visitation. But I mention that in this context because the follow-up from that, the facility that this occurred at, participated in the Healthcare Equality Index and did some extra work on their policy. And I think that you'll find in every case like that the administrators will see that as not representative of the values of the agency or the facility, and that they themselves are surprised by that incident. So when we do the Healthcare Equality Index, our objective is to not only have people discuss the policy language, but bring together the people who work with patients every day, learn about the experiences and maybe gaps in training that exist so that we can get ahead of these situations and avoid them occurring in the future. Another thing that Amy included a slide on, and she's driving the webinar right now, so that's why I'm referring back to her slides. The document that we created this year in support of the report is something called a call to action, because it actually talks about the specific reasons why taking the HEI is a good idea. Of course, there's promoting quality care and preparing for the different types of reform that are coming down the line. Employee satisfaction and complying with regulations. They're two things that I think really resonate with people who are wondering why they should take this survey. We find that when a facility participates in the HEI or in similar activities, there's an increased sense of value among the employees of the diversity at the facility. It helps with recruitment of new employees, as the facility is seen as a standard bearer on patient equality, inclusive of LGBT patients. And also it prepares the facility to address those bigger concerns that come down from the standards and the regulations. Through the HEI, the opportunity is there to see how other facilities are responding to those situations, and thereby you're not in the situation where you're reinventing the wheel. So just to give you a sort of a final overarching pitch for participation in the HEI, I always tell people who have heard about it and may be interested that I encourage them to at least give us a call or send us an email. Let us send you the survey invitation. Like I said, it'll be coming out in the next couple of weeks. And any facility can open the survey and work on it, learn a little bit about where their policies are in relation to some of the other facilities across the country. And if nothing else, you'll have that experience and the resources from the HEI to review. Going that far does not mean that you have to submit the survey and participate in the report. We definitely want you to, but I just want to make sure that everyone feels comfortable that they can access the resources of the Healthcare Equality Index, these model policies, some of the peer-to-peer work that we facilitate, so that you can continue to improve policies. And again, hopefully you will participate in the HEI, but I would encourage people, even if you aren't sure that your facility would be willing to actually submit a completed survey, at least give us a call or an email and let us share the information with you and provide you with the resources that we've developed through the project. So as I said, I want to make sure that I give you the contact information. It's in the PowerPoint, but again, my name is Tom Sullivan, and the email address where you can write to us for participation in the upcoming HEI survey is simply HEI@hrc.org. So I look forward to hearing from everyone in the coming days. And I think we still have a few minutes, so I'd like to turn it back to Amy and see if she has any final thoughts, and we can open it up to some questions.
Great. Thank you so much, Tom. I think this is great. And actually, I want to make one point to the audience, just in terms of one of the potential benefits to participating in the Healthcare Equality Index, but even more importantly, to make sure that your organization has been evaluating its practices and its policies, is the brand loyalty. And Tom and I had the opportunity to spend some time together at a conference that attracted many leaders in healthcare quality. And it was amazing to interact with folks who may or may not have had these issues on their radar, but certainly were the people who are driving a lot of their organization's efforts to promote quality care within their organization. And, one other point is we did have at least a handful of people come by who were likely members of HRC who were very, very thrilled that HRC was present at the conference. And I think that's one example of the brand loyalty that exists within the population as one driver for promoting, or engaging in LGBT patient-centered care. But I think even more importantly to that is that this really is a quality improvement imperative and needs to be, on the radar of our quality improvement professionals. And so perhaps we even have some among our audience. And with that, I'd like to turn it back to Sherry to kind of allow us to take some questions.
Excellent. Thank you, Amy. First, I'd really like to thank Amy and Tom for presenting on this very important topic. I know that these are issues with which healthcare organizations continue to struggle. And then I've received a number of questions, and I'd like to reiterate that the webinar recording and slides will be available after the webinar, and they will be posted to all 3 of our websites. In addition, we've had several questions from people asking how many people actually are participating in today's webinar. Well, I am very pleased. As of last night, when we were checking registrations, we had over 400 registrations. And I've been checking throughout today's webinar, and we've had 322 participate in today's webinar, which I think is a phenomenal response. So again, I thank you all for participating. Now, if you have a question, I've received a number of questions through the question function, so I'll start with those first. But if you would like to ask a question, please raise your hand, and I will be able to unmute you if we get to your question. So let me start with the first question. This question says, I'm not sure if this was related to the Healthcare Equality Index or to the COA 360, but it said, how might the results from the Healthcare Consumer Survey differ from an equivalent survey in the general population? And I think because both of our surveys are actually looking at, they're meant for all of our populations, but we want to make sure that we're being attentive to the needs of all of our patients. So the question is that they imagine that half of the general population might give similar responses, regardless of whom is being polled. So what do you think, Tom and Amy?
If I understand the comparison of surveys, a general population survey on the experience of discrimination in facilities, I think that would be something that you would want to compare to, say, the Lambda Legal study. Correct me if I'm misunderstanding the question, but the HEI is very specific to the individual facility policies, and so yeah, I can give sort of a response to that angle. The HEI, since it's a voluntary survey, we believe and we're fairly certain that the answers tend to represent a more inclusive set of facilities. So the general industry, if you were to go out and start searching for very specifically inclusive LGBT visitation policies, for instance, or patient non-discrimination policies, they would probably not be as inclusive as those found in the HEI. But that said, we have seen a distinct increase in the number of facilities that have responded to the mandates from HHS and also the standards that have been established by the Joint Commission to go ahead and start including very specific language in their policies, which I find is encouraging. So even though it may be that the HEI skews towards the more positive, more inclusive of the facilities out there, we definitely see the overall general industry that there is an increase in the quality of policies out there. Amy, do you have any comment?
Yeah, and I'll take it from sort of a different tact, because I agree with what you said, Tom. But I'm wondering if, and again, I may not understand the question entirely, but in terms of a general consumer survey about their experiences in healthcare, and I wonder, versus a survey targeting the LGBT population, which is what the Lambda Legal survey did. It was targeting individuals who identified as lesbian, gay, bisexual, transgender, and also pulled out individuals who identified as having HIV. So do I think that a general survey of consumers in healthcare would elicit the same response as that, I definitely say no. And you know, perhaps, you know, I do recognize that, yes, there will be responders from the, quote, general population of patients who have been consumers of healthcare that will have experienced some of those behaviors. And those, I'll go back to the slide. Sorry, I'm sending us through all of them very quickly. But if you recall, it had to do with being refused needed care, having harsher abusive language, being treated with disrespect. I think that one of the reasons that I really feel strongly that in a general population survey it wouldn't be so significant is when we look at the difference between the LGBT, or excuse me, the LGB respondents to the transgender respondents. And just in terms of the experiences of the transgender population, because they have very unique needs. It's a much smaller population, but the uniqueness of their needs. And I think they tend to experience interactions with the healthcare system that may be less sensitive and less understanding. And that was nearly a 20% jump in the number of transgender respondents who had experienced one of those insensitive, to say it mildly, experience in healthcare. So I don't know if that was sort of where the question was going in terms of comparing regular consumer surveys to this, but I definitely think that we have a ways to go in improving our care generally to our general population, but I think when we pull out segments of the population that are more vulnerable, I think we sometimes see those experiences to be a little bit less kind.
Great. Thank you. Thanks, Tom and Amy. So, wow, we are completely overwhelmed with questions, and I'm going to see if I can ask Tom and Amy, maybe if I'm able to take the questions offline, maybe we may be able to post a document that has answers to those questions, because I'm sure that many people have some of the same questions. What do you think about that?
Sure, that works for me.
Okay, so I'll try to get through as many as I can. But our next question is, in the case of transgender patients, the person said that he or she felt the only way care will change is once medical insurance carriers start making their policies all-inclusive to cover all care for transgender. Then and only then will we see significant improvement in healthcare to transgender individuals. And they were wondering what your opinion might be on this.
I can say I agree that that is very important, and I think Amy said it right at the beginning that unfortunately an hour-long webinar isn't enough to cover all the range of disparities and discriminatory experiences within healthcare, which covers everything from patient policies to health insurance to provider cultural competence. So I can only say I agree, and we hope that the process of engaging the healthcare industry in a discussion of the discrimination experienced by LGBT patients, and specifically talking about, as Amy said, the specific types of discrimination experienced by transgender patients, that it opens that discussion that leads to the overall issue of insurance and provider competency. So, Amy?
Yeah, I 100% agree with Tom, and with the person who posted the comment. I think there are efforts, I believe, to promote more inclusive policies, and I think there's some statewide efforts that are occurring. But didn't I mention one of the slides that we have a long road ahead? So, but a very good, very, very good question, very good point.
Great. I'd like to turn and unmute. I see we have a hand raised from Ryan Shields. And Ryan, if you would still like to ask a question, I'm going to unmute you. Okay, you can go ahead. Hello, Ryan? Okay, we have a hand raised from Kate Odell. Kate, I'm going to unmute you. Kate? Hello? Okay, nope, put a hand down. I'm going to go through, let's see, Pam Bell. If you have a question, I can unmute you. Hello, Pam? Okay. Hopefully I'll find someone who would like to ask a question in person. Let's see, I have a question from Christine Pluvios. Christine? Christine, would you like to ask your question? Okay. And Ryan, you are still unmuted if you would like to ask your question.
Cherie, have there been any questions that have been posted that you could read off to us, perhaps?
Yes, I was trying to basically alternate because we have about 30 questions, and so I didn't want to just be me speaking. But sure, I will go back to that. So here's another question. The question is, I wonder what the challenges are for providers who aren't educated on how to talk with their patients. In addition, being afraid to say the wrong thing, therefore potentially offending a patient, which I think is an excellent question.
This is Amy. That's a wonderful question, and I think that's where we have to give ourselves some breathing room to realize that cultural competence in its general sense is a journey. It's sort of this goal that we have for ourselves, but we're always going to be learning on it. I think one of the things I've learned in this work is even the terminology changes a lot. I mentioned at the beginning that I'll be referring to LGBT. There are those that would not like it to not include LGBTQ. And there are a number of different acronyms. But I think this is why it is important for providers to be trained on how to respectfully ask questions and to be open. I think some of those individual behaviors in terms of not making assumptions, asking patients, how would you like me to refer to you? How would you like to be called? And some of those can help create that comfort zone. And generally, and I think if we are truly trying to understand our patients, patients are willing to help us understand. And I think the behaviors that really turn patients off are when, providers show obvious signs of disgust or just complete confusion, or do things like, I'm not prepared to address this. So I think, one of the things that I think sessions like this even can do is help bring this topic up for discussion. And I think also creating those safe spaces where people can say, hey, I'm afraid of offending people. And, you don't want your fear of offending to cause you to completely mute and not share information. So I don't know if I've really given a clear direction. I think there are efforts to create more specific curriculum in, the medical and in the medical professions to help train physicians and nurses and physicians assistants in these areas. But again, even with general communication effectiveness, we have a long way to go.
And I would agree with Amy also, everything that she said. And to the questioner, the point that they bring up is something I think we hear all the time, that people feel that they don't have the resources needed to provide culturally competent care, or also have a fear of offending someone by saying the wrong thing. And to that end, with the Healthcare Equality Index, the objective is not just to ask people what they're doing and then weigh out the answers. We actually actively try to provide resources, and that includes training. So we have been trying to do some in-the-field training at facilities in different places around the country. So part of participation in the HEI will open the door for us to provide some resources, perhaps some in-person training, and also referrals to some of the other great resources out there. There are groups like the Gay and Lesbian Medical Association, for instance, that does some wonderful materials on cultural competency for providers. So the question is very on point. It's something that so many facilities raise, and as for our part, we want to make sure that we're not just asking a question about policy, but actually providing some guidance on where people can find resources and training.
Excellent. I'd like to take one last question, and again, I'd like to thank you for all of your questions. I will make a note of all the questions, and I will be sending them to Tom and Amy, so hopefully we can post those. One other question, too, was whether the website, Amy, that you mentioned, the Joint Commission website about the roadmaps, whether that would be available. I think we'll be able to just include a list of the resources with their web links on our various websites as well, so that should get to that question. The one last question I have is actually, this one is for you, Tom, and it says, has HRC considered expanding the HEI to include fields besides healthcare? Social service agencies could benefit from the same. Surveys, questions, and discussions.
Yes, that is an excellent question, and it's something that comes up all the time. We do have several different programs within the Human Rights Campaign that talk to different parts of the workforce, whether they be in healthcare or, say, in child services through work the Family Project here does with foster care agencies and adoption agencies, or other, even if they're businesses, we have resources for those. But the answer is yes. I think the challenge for us is to find a core group of people who can work together to then create that resource. So I would welcome any direct input. You can write either to my HEI email, or you'll have other contact information for me, I'm sure, after this webinar. But just to say, the way that HEI came about is it was a gathering of leaders in the healthcare field and LGBT health advocates who sort of set this standard. These are the policies that we should all be looking at, and from that it led to the HEI. So in that context, I would say that would be a great resource. We just need to continue to bring together people who are interested in working on that subject matter.
Excellent. Thank you. I see Dr. Leviste is on the call. Dr. Leviste, did you want to say anything? He's our center director. No, I don't think so. Okay. Well, again, I would like to thank everyone for joining our call. You will be receiving, after this webinar, a link to an online evaluation, as well as the links to all 3 of our websites. And we will be posting the webinar recording, as well as the slides, as well as the list of resources to our websites as well. If you have any other questions, some people have been emailing me directly. Please do that. And then I can send these to Amy and to Tom, and hopefully we can post the responses to your questions as well. Again, I'd like to thank you for participating. Have a great rest of the afternoon.
Thank you so much, Cherie. Thanks, Tom.
Thank you.
Thank you.
Bye.